So today I'll be talking about SNOT22 subdomain outcomes following treatment for sinonasal malignancy, and just a brief reflection on this experience. So as mentioned, I'm a Stanford medical student, and I have just applied for residency training into otolaryngology, or ENT. But prior to applying into ENT, I wanted to take a dedicated research year to really get to know some of the patients that I hope to serve in the future and what will hopefully be a very long career. So I talked to Dr. Wong about some areas of ENT that really deserved a lot more focus and research and exploration, and he kind of guided me towards sinonasal malignancies. And when I looked into the literature about what we knew about sinonasal malignancies, especially compared to other areas of ENT, I was surprised at how far behind it felt like we were compared to some of these other tumors and cancer types that we know so much about. So I applied to be a Stanford Medical Scholar Fellow and was given funding for the year to explore some of the unknowns of sinonasal malignancies. As Dr. Wong mentioned, this research was presented at the 69th annual meeting of the American Rhinologic Society in Nashville just about a month ago. And we've submitted this work for publication and has been favorably reviewed by the International Forum of Allergy and Rhinology, and we are expecting it to be published by before year's end. So, brief background, as many of you have heard today, studies on sinonasal malignancies are limited because they're so extremely rare. But this CORSICA working group has really changed the game in my mind. And as you've seen from some of the other research groups, we've started to publish long-term sinonasal quality of life outcomes data. And the goal of this study was to do something similar, but kind of look at those quality of life metrics in a more granular fashion using something called the subdomains, which I'll talk about more in a second. So the objectives were to explore short-term and long-term changes in SNOT22 subdomains by quality of life category following the treatment of these sinonasal malignancies. We wanted to identify patient demographic and treatment factors that drove these changes in the SNOT22 scores in specific quality of life categories. So to do that, we used the CORSICA database. We looked at symptom scores collected before surgery and after surgery for about 5 years post-op, which is a pretty unprecedented duration of follow-up when it comes to the exploration of these types of cancer. We looked at demographic information, tumor characteristics, and treatment factors such as surgical management, radiation treatment, chemotherapy, surgical margin status, as well as other factors such as intracranial involvement. We then looked at the SNOT22 categories measured at each time point, which kind of can be categorized into these buckets like nose symptoms, non-nose but related symptoms, so like cough or postnasal drip, ear facial symptoms, psychological symptoms, and sleep symptoms that come with carrying this burden of a sinonasal malignancy. The study cohort consisted of 234 patients. As you can see, there's a strong distribution of multiple tumor types, and 21 of which were the SNUC sinonasal malignancies. So when we looked at the nose symptom scores for patients who were treated for these sinonasal malignancies, we found that over time, the symptoms improved. So if you look at the scores on this graph here, the higher scores are worse scores. And over time, that bar gets lower and lower, depicting their improvement. We found that patients who were treated with chemoradiation or had tumor involvement of key structures, as Sabrina previously mentioned, the pterygopalatine fossa, they had worse quality of life outcome scores. When we looked at patients' ear and facial symptom scores, we again found a score reduction that was pretty comparable to the baseline, with worse quality of life associated with chemoradiation, and again, that pterygopalatine fossa involvement. Then when we looked at the non-nose but kind of related scores, so like your cough, your postnasal drip, we again found that over time, following treatment, these patients improve with worse quality of life associated with chemoradiation exposure once again. And then when it came to sleep, again, improvements over time in these subdomains, with worse quality of life associated with adjuvant radiation. And then finally, when it came to the psychological symptom scores, for the final time, but again, improvements over time over this 5-year duration, with worse quality of life associated with patients who have a combined endoscopic open surgery, so bigger tumor resections that require larger surgeries would report worse psychological symptom scores, as well as patients who have the positive tumor margins following the surgery, so visible disease remaining. So these are kind of the tumor margins that are positive, as Sabrina had mentioned. But to summarize, patients with sinonasal malignancy present with really poor quality of life at baseline. However, following treatment, these patients experience improvements in all categories of quality of life as measured by the SNUC 22 scores. We found that decreased quality of life may be noted in patients with open surgery, with the key structure involvement, so pterygopalatine fossa, as well as those who've had chemoradiation therapy, adjuvant radiation therapy, and the positive margin status. I took a lot of time to reflect on what this year meant to me and what I took away and the patients I met and the impact it's had on my career. And I felt like through the process of looking through the data, spending hours kind of poring over it, I really got snapshots of patients and their journeys managing and battling sinonasal malignancies. And while no database in the world can fully encapsulate what it means to have any type of cancer diagnosis, it really was a privilege to get to know some of these patients. And then when I met many of them in the clinical space, I think the demonstrated impact of what the CORSICA initiative is doing was very clear to me. Hearing patients share laughs with loved ones, or hearing a story of a grandfather celebrating another birthday with a new grandchild they never expected to meet was really impactful to me. Through this CORSICA initiative and the studies that follow, I feel like we really give a voice to the patients who have battled these cancers and make their stories known. So I look forward to working with this team and behind this initiative for hopefully many more years to come. And I just really want to thank you all for taking the time to listen to us, for establishing this foundation, this initiative. It's truly been a pleasure to be a part of. So thank you.
Thank you, David. That was wonderful. We look forward to watching your career in ENT take off. We have an interesting question in the chat. Are these cancers still terminal in 5 years with the improved quality during that 0 to 5 years? Perhaps another way to phrase the question would be, this is about quality of life, but it's not affecting survivorship or survivability. Is that correct?
Yeah, so as some of our collaborating groups have mentioned, these patients present with really poor baseline quality of life. So we were looking at patients who were treated with what we call curative intent. So the tumor's been fully removed, or with the adjuvant therapies, we've essentially cured these patients of their cancer. And so we want to see like how well do their symptoms improve over time after they have been treated for these sinonasal malignancies. And we were really pleased to see that a lot of these areas, these categories, these subdomains improve to almost pre-cancer levels when you compare them to studies looking at where patients who don't have cancer, where their scores sit.
So these were patients whose cancer did not return?
Exactly. So these are patients who did not have recurrence of their cancer.
I see. There were two terms that you used. I wonder if you could just distinguish them. It seems clear from everything we've heard so far that radiation is really standing out as something that is not helpful for quality of life. You talked about adjuvant radiation versus chemoradiation. What's the difference?
So adjuvant radiation is radiation therapy kind of following a treatment. So basically, our radiation oncology colleagues will use adjuvant radiation for a real targeted approach to areas that may have residual tumor, while chemoradiation oftentimes will include chemotherapy and the adjuvant radiation therapy. So with chemotherapy, that's oftentimes more of a systemic therapy through medications, while adjuvant radiation is more targeted and is a slightly different approach.